guys, and now we are starting the respiratory system. In the respiratory system, we are starting with the anatomy of the lungs. Which things you have to remember in the anatomy of the lungs? We are starting with that. The first thing you have to remember all about the airways of the respiratory system, because when you are gonna study about the diseases of the respiratory system, we have to remember the general anatomy and the physiology, right, of the respiratory system. So we're starting with the airway generation. So as you already know from your basic knowledge that this about the airway generation, we have total 23 generation of airways are present in our respiratory system, right? And out of this 23, the trachea, right? The trachea is the generation 0, right? The trachea is the generation 0. It means the airway generations are starting from the trachea only, right? From the trachea it is going to start, right? And after the trachea, the generation 1 to 16, like starting from the trachea, after the trachea, bronchi, bronchus, and the till the terminal bronchioles. These are the starting 16 starting 16 airway generation, and these generations are known as your conducting zone. Please remember about this all 16 are known as your conducting zone. What do you mean understand by the conducting zone? It means they are having just the work of it, they are doing the conduction. What the mean of conduction? They are like tube like structures are there which are conducting the air. There are the no respiration occur in this starting 16 generation. यहाँ पर respiration नहीं होता है. There is a no respiration, just they are conducting the air. They conduct the air from the trachea to this all the 16, right? It means this all the starting 16 generation don't have any kind of respiration work. Understand? Then the air conducting zone, this air in this conducting zone is known as the anatomical dead space. Please remember. So जो air है, right, what the air collected in this conducting zone, it's not having any respiration, so that's why this zone is known as also the anatomical dead space. It means the anatomically it is am, but dead space, it means they're not having any respiration in this starting 16 generation. And this is the volume of the anatomical dead space. Please remember the 150 ml is the anatomical dead space, right? So you have to remember about it. The all the 16 generation, all the 23 generation, after this 23, they're starting 1 to 16 generation are the having the conducting zone. And this conducting zone is also called as our anatomical dead space, right? If we talk about the generation 17 to 23, this are called as the respiratory or alveolar zone, right? This called as a respiratory or the alveolar, because in these last 17 to 23 generation, they are having the respiration. They are working in the respiration, right? They are having the respiration here. And these are comprises of the respiratory bronchioles, alveolar duct, and the alveoli. These three are, these are in this respiratory zone. So in the respiratory zone, we are having what we are having? We are having the respiratory bronchioles, alveolar duct, and the alveoli. So these three are in our respiratory zone, right? And as you know, the transition zone is 17th, 18th, and 19th, right? What do you mean by the transitional zone? Please remember, right? हमारे पास क्या है? तीन zones है. The first is our conducting zone. There will be the no respiration. Then we are having the respiratory zone where will the respiration occur. What the mean of transition zone? The conducting zone now changing into the respiratory zone, right? So where the changes occurs, the transition occurs, this is known as the transitional zone. And this transition zone is our 17th, 18th, and 19th, which is your respiratory bronchiole, right? So respiratory bronchiole is known as our transitional zone. Here what is happening? Here the conducting zone is converting into our respiratory zone, right? So please remember about it, about your conductive zone, your respiratory zone, transitional zone, and about the anatomical dead space. Please remember the volume of anatomical dead space. It is your 150 ml, right? I hope you remember this all from your journal anatomy and the physiology, right? From the physiology knowledge. Starting with the now diseases part, in the first, I'm starting with the pleural diseases. So we are starting the diseases part, and the diseases part, I'm starting with the pleural diseases, right? In the pleural diseases, we are having the first is our pleural effusion. What we are having? We are having the pleural effusion, right? If we talk about the pleural effusion, we are having the pleural cavities. I hope you know about it from your basic knowledge that we are having the visceral pleura and the parietal pleura. Like two type of the pleura is there, right? One is which is the outer covering, the second which is covering the lungs. So in between this, we are having a space between the visceral pleura and the parietal pleura layer. We are having a space which is known as our pleural space, and this pleural space is normally having the normal pleural space is having the volume of 1 ml, right? The normal pleural space is having of the space of 1 ml, right? But if there is an abnormal collection of fluid in pleural cavity, right? What is the pleural cavity? You already know, visceral pleura, between the visceral pleura and the parietal pleural layer. So in between, if there is some abnormal collection of the fluid will be occurred there, is there, then it will be known as the what it known as a pleural effusion, right? So you understand, normally what we are having in the normal pleural space is the 1 ml, and there we are having the pleural fluid, right? Which is doing what is doing, they are doing the lubrication and not doing the compression there, right? Lungs when are expanding the lungs and recoiling the lungs, so it is helping in that. But if what is happening, if abnormally there's some collection of fluid within the pleural cavity or more there, not the normally 1 ml is there, but if more than 1 ml is there occurring, then this is known as the pleural effusion. And please remember where it's the fluid will be accumulated. It's accumulated between the visceral pleura and the parietal pleural layer, and it is our known as our what is known as our this is known as the pleural cavity, right? And if we talk about the pathological process, what are the pathological process? These are the primary lung, or maybe can cause the other organ system also, which is known as the systemic disease. So some diseases which are there, they can cause like primary they are causing by the lung diseases, rather than the secondarily other than they are causing by the other organ systems also can cause this thing, right? So you can see here by the diagram only you can understand, this is the outer one is our parietal pleura, right? And which is covering your lung totally. This is your visceral pleura, right? Between this both of the layer, we are having the pleural cavity, right? And you can see here, if in this pleural cavity is there, if air is going to accumulate it, you can see here, this is the air. If air is there, this is known as the pneumothorax, right? This is known as the pneumothorax. And if there will be the only and only fluid is going to accumulate it, you can see in this diagram. In this diagram, there is a fluid gonna accumulate it. This is known as the pleural effusion. But if there exudate is also and the air is also, right? If both is there, this is known as your empyema, right? You can see here the air is here and the exudates is there. This is known as your empyema, right? So please remember pneumothorax, right? And pleural effusion, difference between it, right? If the air is accumulated in the pleural space, right? In the pleural cavity, this is known as the pneumothorax, right? If water is there, hydrothorax, right? So please remember about it. Now we are going about the pathophysiology of this. In the pathophysiology, if you ask normally, if you are seeing the normally, what is happening? They're entering via capillaries in the pleural space. The normally, the normal pleural fluid is coming, they are entering from the our capillaries, right? And they removed by, and this removed via lymphatics in parietal pleura, right? So this is coming from the capillaries of the parietal pleura and removed by the lymphatics in the parietal pleura, right? So you can see by this diagram, this is coming from the, this is the capillaries and this is coming from the capillaries of the parietal pleura. After in the coming into this pleural space, this pleural filtration, after this pleural filtration, you can see there is a costolymphatic and di- diaphragmatic lymphatics and the mediastinal lymphatics. After this lymphatics, they will be going to remove it, right? So this is the normally. But now what is happening? So if any condition is disturbing either of above two results in the pleural effusion. If there is a more and more capillaries, filtration will be there. Like the normally it is coming from the parietal pleural filtration, right? If it's increasing more, right? If hua kya, there is a more parietal fluid is coming from the capillaries, so there will be the more accumulation of the fluid. Or if there is a filtration, after the filtration there is a removed by the lymphatics, or there is a damage in this lymphatics, or the lymphatics is not working to remove this fluid, there will be causing the pleural effusion, right? So this fluid can also enter pleural space throughout the intestinal space of the lung. What is happening? The intestinal space of the lung, there ये वहां से भी क्या हो सकता है? It can come outside, or maybe from the visceral pleura it can also come, right? From the visceral pleura it can come outside into the pleural space, or from the peritoneal cavity, right? From the peritoneal cavity, it's also come via the small hole in the diaphragm. So if diaphragm is having the small hole will be there, it can come from there also. So please remember the normal pathophysiology of our pleural fluid is there, that normally it is coming from the parietal pleural capillaries. Parietal pleural capillaries are entering in the parietal pleura, and this is after the filtration it is coming into the pleural cavity. But after this coming here, the lymphatics, which three lymphatics we are having? We are having the diaphragmatic lymphatics, we are having the mediastinal lymphatics, and we are having the costal lymphatics. So these are going to remove this fluid from there through the lymphatics. It's gonna drain out. But what is happening in the pleural effusion? Out of this two, these both are the physiological normally, but if they are going to disturb, maybe there is a more and more filtration by the capillaries of the pleural fluid, or maybe there is a lymphatic cannot remove this fluid, so it can cause the pleural effusion, right? And other than also the fluid can come from the interstitial space of the lung, or maybe from the visceral pleura also can, and from the peritoneal cavities also can give this fluid by the small holes in our diaphragm, right? So this is the image. You can understand from this how this normally lungs is working. But if there is a disturbance between this pathophysiology, then there will be the accumulation of more and more fluid, right? And now, if we talk about the effusions, this effusions may be the transudates, and this transudate effusion is known as your hydrothorax. As I already told you, translucent, transudate, it means it is having the clear-like fluid, right? Clear watery-like fluid, and if the water-like fluid is there, this is known as the hydrothorax, right? This is known as the hydrothorax. And some more systemic factors that influence the formation and absorption of pleural fluid are altered. Maybe some systemic factors are also there that can cause the systemic diseases, can cause this disturbing these factors, right? So you can see like the pleural membranes. If there is a pleural membrane is getting intact and not involved in the pathogenesis, right? And the permeability to the proteins by capillary is normal here. So you can see here, this is the capillaries, and after this capillaries, you can see this water is coming outside. This transudate effusion is coming outside, and this because of that, this is known as the hydrothorax, right? This is known as the hydrothorax, and you can see this water is now filling in the pleural space, right, between the visceral pleura and the parietal pleura, right? So this is going to accumulate there, and this is known as your hydrothorax. Please remember about the hydrothorax, right? Now, if we're talking about the more exudative pleural effusion, some local factors are also, right? What are the local factors? They are growing in the formation of fluid are altered, right? What these local factors? These local factors are increasing the fluid production, right? हमने बात करी, देखो, we already taught you about it. If there is a cavity is there, like I'm giving you the example, the water tank, always one water tank is there, the if output and input and output is equal, so the same input amount is coming, same output is going on, there will be the no accumulation of fluid in the water tank. But if the water tank input is increased and output is low, so it will be accumulated in the water tank only. Or if the input is normal, the output is blocked or stopped, there will be the accumulating in the water tank, right? So the same system is here also. If there is with the lymphatics are blocked or the lymphatics are not removing this, the accumulation of the this pleural fluid will be there, right? Rather than if the pleural fluid formation is more, right? If pleural fluid formation is more, so the more and more fluid will become there, but the lymphatics will remove very less, right? So what are these local factors? Please listen this. The first is that altered the permeability of membrane. As you know already, the permeabilities are there, right? The water permeable or not. So if the changing the permeability of this pleural membrane, right? This parietal pleura membrane is permeability is changed, so there will be the more and more fluid will be coming into our pleural space, right? Or maybe there is an increasing the capillary wall permeability. As you already know, this is known as the vascular disruption, right? Permeability of protein is high. If the protein is very high, the permeability will be the increase in the capillary wall, right? And the maybe there will be the third is the decrease the complete obstruction of the lymphatic drainage of the pleural space, right? So as I told you, is there the altered in the permeability of the membrane, there will be the more formation of the pleural fluid, the first thing. Or if there is increasing the capillary wall permeability, like vascular disruption will be there, there will be also the more and more formation of our pleural fluid, right? And with this also, you know about it, if there is a decrease or the complete obstruction of the lymphatics will not remove this pleural fluid, so this pleural fluid will be accumulating there and there only, and there will be increasing in our pleural fluid, and this is the exudative pleural effusion, right? So now we have to talk about the two main difference, the transudative and the exudate, right? What is the difference between the pleural effusion, which is the transudate, and which is the exudate? So starting with the first thing, which is about the cause of it. If we talk about the cause of the transudate one, there will be the increasing in hydrostatic pressure and decrease the colloid osmotic pressure. And if there is a disruption between this hydrostatic pressure and this colloid osmotic pressure, there will be a disruption. Due to this disruption, this water will leaks out from the capillaries. And this leaks out from the capillaries. This is clear fluid will be there, right? That's why this is the transudate. This will be the clear fluid. Please remember about it. If we talk about the exudative, there will be the inflammatory cells will be there. There will be the some inflammation is caused there, right? What is the cause of it? There is a cause is the inflammation. Some inflammation is going on in the lungs, and due to this inflammation, there is the production of the exudates will be there, which is nothing, which is our inflammatory cells is there, and our helper cells, T helper cells, right? So these are the exudates only, right? If we talk about the appearance of it, how we get to know by the appearance of it is the transudate or the exudate. So please remember, the transudate will be the always and always clear transparent color. If we talk about the exudate, it will be your cloudy color, right? Cloudy, it means it will be not transparent, right? It will be not the transparent. But if we talk about the transudate will be the clear like water. Okay. The third thing, there will be the difference, how we get to know the specific gravity will be there. If we talk about the specific gravity of transudate, it will be always and always less than 1.012, right? It will be less than. But if the exudate is always having the more than 1.020, right? So there is a specific gravity difference will be also there. So what we can do, we can take out this fluid and we can check about the specific gravity of this fluid also, right? So we'll get to know. The fourth thing which we can differentiate this thing, the fourth thing is about the protein content. If there is a transudate is there, there will be the less than 3 gram per liter protein will be there. But if there is a exudative will be there, the exudative will be having the more than 3 gram per liter, right? So we can collect the protein, we can collect this fluid from the pleural cavity, and we can do the test for the protein, like how much protein is available in this fluid, right? From this also we can get to know about the transudate or the exudate will be there. The next thing is about the fluid protein and serum protein divisions, right? The fifth thing, if you are dividing the fluid protein and the serum protein, right, the ratio will be coming, if less than 0.5, it will be the transudate. If there is a more than 0.5, it will be the exudate. So what we are doing, we are counting the fluid protein and divided by the serum protein, right? So we'll get the ratio, and this ratio will be the less than 0.5 in the transudative and more than 0.5 in the exudative part. And the last thing, we can count about the fluid LDH and this serum LDH, right? So if we're dividing the fluid LDH and divided by the serum LDH, we are getting here less than 0.6 or maybe less than 2 by 3 is there, right? And if it is more than 0.6 or more than 2 by 3, this will be the upper limit for the serum one, right? So this will be the exudative. So this is the main difference, how we get to know this is the transudative or the exudative pleural effusion, right? So I hope you remember with this how we get to know about the transudative and exudative. So in the transudative, there will be increasing in the hydrostatic pressure, the cause is there, and decreasing in the our colloidosmotic pressure. Rather than the exudative will be always and always inflammation is there. By the appearance also you get to know if there is a clear fluid like structure, watery like fluid is there, that will be our transudative. If there is a cloudy or maybe different colors of the fluid will be there, right, not transparent, it will be our exudates, right? And by this the test we can get to know about the specific gravity, proteins, and the fluid protein serum protein division, right? And the LDH, about the fluid LDH and the serum LDH divisions, right? So this is the criteria to get to know about the compare between the transudate and the exudates, right? If we talk about the exudative causes, so in the exudative causes, we are having the first one is our neoplastic diseases. As you already know, in the neoplastic diseases, we having the metastatic diseases like breast carcinoma or lymphoma or mesothelioma, right? So there's a neoplastic causes will be there. Like, is there is a breast carcinoma? Is the inflammation is going on, right? Breast carcinoma is there, and lymphoma. You already know about the mesothelioma, right? From your pathological knowledge. So if the neoplastic diseases is going on in this thorax, in the thorax cavity, right? So it will be going to accumulate in the pleural cavity. The second is, if we talk about the infectious diseases, in the infectious disease we are having maybe the bacterial infection can cause, fungal infection, viral infection, and the parasitic infection can also cause this exudative cause of the pleural effusion. And the important one is about tuberculosis. Please mark as important, tuberculosis is also causing the pleural exudative type of the pleural effusion. With this also we are having some collagen vascular disease like SLE and the rheumatoid pleuritis. So this are about the collagen vascular diseases which can cause the exudative type of pleural effusion. And the last one is our gastrointestinal disease. In the gastrointestinal disease, pancreatic diseases, and the diaphragmatic hernia. From your surgery knowledge, you already know what is the mean by the diaphragmatic hernia, right? The peritoneal cavity or the abdominal cavity organs trying to pierce out this our diaphragm and coming into the thorax cavity, right? So in these cases, we are seeing this exudative cause of the pleural effusion. As you can see, this is the bottle filled with the exudates, right? Exudative pleural effusion, we collected it. You can see this is the yellow pale color like cloudy structure. This is not the transparent. So by the appearance also, you will get to know there is a what is the cause of the is the exudative or the transudative, right? Some drug induced also. So some drugs also inducing the pleural effusion. Like if we talk about the nitrofurantoin, right? Bromocriptine, dantrolene, and amiodarone. So these are causing the drug-induced pleural effusion. If the patient is taking from the prolonged time this drug is using, so this drug also can cause the side effect as the pleural effusion, right? Which one? Exudative. Please remember the exudative type of the pleural effusion. The sixth one is about the mixed syndrome. Please remember about it. This is very important of you. In this mixed syndrome, what is it? This is the triad. It means it is having the three symptoms. The first, it is having the ascites. The second, it is having the pleural effusion. And the third, it is having benign ovarian tumor, or we can say the fibroma. What we can say? We can say the fibroma. So the three thing in the mixed syndrome. In the mixed syndrome, what we are having the triad of thing. The first ascites will be there, pleural effusion will be there, and the ovarian tumor, benign ovarian tumor like fibroma will be there. So this is the mixed syndrome where we can see the exudative type of pleural effusion are seen there. The next is we can see in the asbestos exposures, we are seeing the oxidative type of pleural effusion. As you already know what is the asbestos, right? And uremia can also cause the pleural effusion. And some iatrogenic injuries. What do you mean by, sir, this iatrogenic injuries? If you are doing if there is some doctor is doing any procedure or the surgery, due to this doctor's mistake, is there caused defect in the diaphragm, or maybe the some pleural tear will be there, right? So due to this iatrogenic injuries, maybe there will be also seen the pleural effusion. And the last one is our very important. Please remember the yellow nail syndrome. You can see here in this patient what you are seeing the yellow nails, right? You can see here the nails which are growing there, these are the yellow color of it, right? So this yellow color, yellow nail syndrome, what is this? This is the primary lymphedema, right? Lymphedema associated with the yellow nail and the pleural effusion. So in this yellow nail syndrome, what we are getting? We are getting this primary lymphedema. Due to this, what is happening? The color of nails is will be yellow, and there will be are seeing this, the pleural effusion will be seen. So these are the main factors of exudative cause of our pleural effusion, right? Now we are moving further for the etiology, the exudates etiology. What is the etiology can cause the exudative pleural effusion? So the mnemonic for it, we are having the TB infection and miscellaneous. Please remember, this is the mnemonic, right? What is the mnemonic? The mnemonic is the TB infection and miscellaneous. So from the TB, the T stands here for the tuberculosis. The B stands here for the bronchogenic carcinoma. Also, we can say the lymphoma, leukemia, and the mesothelioma. All kind of the bronchogenic carcinomas are there. I stand for the infections, maybe the bacterial infections, fungal infection, parasitic, viral infection can cause it. Then pneumonia, and stand for your pneumonia, the pneumonia, right? The pneumonial infection can also cause the pleural effusion. Next is about the F stand here for the fistula. The our ventricular tracheo uh, tracheoparietal, there will be the fistula will be there, and due to this fistula there will be the accumulation of fluid, right? And esophageal perforation, please remember about it. Maybe there is the perforation seen in the esophagus, it can also cause them, there will be the pleural fluid will be accumulated, right? C is about the collagen diseases. As we already talked about the collagen disease, the SLE and the rheumatoid pleuritis can seen will be there. The trauma can also cause, if there is an external trauma or maybe iatrogenical trauma will be there, that also cause our the exudative pleural effusion. And intra-abdominal abscess, as you already know, if the intra-abdominal abscess will be there, right, so it can cause also come into the pleural cavity through the herniation of the diaphragm or the some small openings or small holes in the diaphragm, and it can reach to the pleural cavity. And the ovarian hyperstimulation syndrome, OHS. I hope you read about the OHS in the obs and gynae, right? From the ovarian hyperstimulation syndrome, also we are seeing the exudative pleural effusion. And some numerous of the drug, as we already talked about the amidron, nitrofurantoin, hydrazine, cabergoline, these all are causing the this exudative exudative pleural effusion. And the ARDS syndrome, right? Acute respiratory distress syndrome is also causing. And if we talk about the miscellaneous, in miscellaneous, as I already told you, the mixed syndrome, yellow nail syndrome, right, and trapped lungs are the things which can cause the exudative pleural effusion. So you have to remember this. That's why I given you the mnemonic of it. Please remember this mnemonic. This mnemonic is very, very important. Through this mnemonic, you will remember the all the exudative etiology causes, right? Please remember TB infections are miscellaneous. TB infection and miscellaneous, right? So please remember this list of the all the types of etiologies are here, right? Now, if we talk about the transudative causes, if we talk about now the transudative, till now we talked about the exudative causes, but now we are going for the transudative causes. In the transudative causes, the systemic factors that influence the formation and absorption of the pleural fluid are altered. What are the systemic factors? Please remember, these are the systemic factors which can influence the formation. What the mean of influence? They can increase the formation or maybe they can decrease the absorption. So this can be altered, seen in the CHF, congestive heart failure. Also can seen in the cirrhosis, pulmonary embolization, nephrotic syndrome, peritoneal dialysis, SVC obstruction, superior vena cava obstruction, and the mixed edema. These are the important 7 causes. Due to this, there will be the altered or the influence of the formation or the absorption of the pleural fluid are altered. Like if we talk about here, you can see this is the healthy heart. You can see this is the healthy heart, the superior vena cava, inferior vena cava, dropping all the blood and coming into the commonly coming into the our right atrium, and from the right atrium it's go to the right ventricle. To this right ventricle, this is go by the pulmonary arteries to the lungs, and it is coming back to the left atrium and the left ventricle through the aorta. It is going out. But can you see this is the normally it is working, but you see here this is the congested heart. As you see here, you can see the left ventricle size in this normal heart, and here you are seeing the left ventricle or the right ventricle are the dilated. This is the congestive heart, right? And due to this congestive heart, there will be the altered between the influence of systemic factors, and due to this, there will be the same the transudative uh, pleural effusion will be seen there, right? If we talk about the etiology of this transudative causes. So please remember as a champion, this is the mnemonic. Please remember the mnemonic. What was about the exudative one? Exudative was mnemonic was the TB, infections and miscellaneous. But here in the transudative, we are having the mnemonic, the champion. So champion C stand of the congestive heart failure or the contractive pericarditis, right? If we talk about the H stands here for the hepatic cirrhosis or the liver cirrhosis, right? The liver cirrhosis is also altering the our things, the altering the or the influencing the our formation and absorption of pleural fluid. The albumin low, if hypoalbuminemia, right? If albumin will be low there, because albumin is our binding protein, right, in our fluid, right? So if the binding protein is low, there will be the altered in our osmotic pressure and hydrostatic pressure, and due to this altering in this pressure, there will be the secretion of or the absorb or the formation of more and more pleural fluid will be seen. The mixed edema and the mixed syndrome, malabsorption, in this also we are seeing this. In the peritoneal dialysis also we are going to see the transudative cause of the pleural effusion. L stand for I stand champion, I stand for the iatrogenic, may be seen in the our extravascular migration of CVC, right? O stand here for the obstruction of the superior vena cava or can be the obstructive uropathies will be seen. And the last N stand here for the nephrotic syndrome. So these the list of the transudative etiologies which can cause the transudative pleural effusion. So you have to remember by the mnemonic of champion, right? So you have to remember by the mnemonic of champion, right? Now we are going for the next thing. The pleural effusion can be caused in the left side of the lung or maybe the right side of the lung. But what are the causes can cause only and only left side or only and only right side of the causes. So first we are starting with the predominantly left side, which are causes which can causing the predominantly to the left side of the left side of our pleural effusion. So if there is a acute pancreatitis or esophageal rupture and the Driscoll syndrome. These are predominantly, if this is the cause of the pleural effusion, they will be going to cause into the left side of the pleural cavity will be involving there. So what we are seeing the left lung pleural effusion, but predominantly some factor which are causing the predominantly predominant the right side of the lung, like amoebic liver abscess, liver cirrhosis, and the mixed syndrome. If these are the causes of the pleural effusion, they will be going to predominantly including our right side of the heart. So some diseases are there which are depending also in this, right? If there is a pancreatitis is seen, so what is the our thing is saying this will be the predominantly is it is going into the our left side of the lungs will be going to involve in the pleural effusion, right? If we talk about now the clinical features of our pleural effusion, what will be the clinical features are seen with this? The first thing will be seen is the dyspnea. What will be seen? Dyspnea. As you already know what the meaning of the dyspnea. Dyspnea, there will be the difficulty in breathing. With there, we are seeing the cough and chest pain. What will be there? There will be the dyspnea, right? And chest pain and cough will be there. If we talk about the some other symptoms which can suggest the etiology, like severe cough with the purulent discharge or the bloody sputum can be seen in the pneumonia. As you are seeing in this image, you can see this with the patient is having the this purulent discharge, yellowish purulent discharge, and this bloody sputum will be seen in the pneumonic patient. And the constant chest wall pain, right? The chest wall invaded by the bronchial carcinoma. If there is a constant chest wall pain is there, or maybe the malignant mesothelioma will be there. So due to this chest wall invasion of this carcinomas and mesotheliomas, it can cause a chest pain, and the constant chest pain will be there. If we talk about the pleuritic chest pain, in the pleuritic chest pain, maybe there will be the pulmonary embolism or some pleural inflammation is going on there, right? And the last one, the systemic toxicity, and this will be seen in the empyema, right? So please remember the common clinical features will be the dyspnea, cough, and the chest pain will be there, and some other features which are suggesting the etiology, like if there is some purulent discharge in the blood will be there, the pneumonia can cause it, right? And if the constant chest wall pain is there in this patient, so there will be the invasion of the bronchial carcinoma will be there, right? Now we are going for the next thing, which is the physical examination of the patient. What will be the physical examination? If we are seeing the diminished, the chest movement on one side, if unilateral pleural effusion is there. So as we are seeing, the patient is taking the respiration, our chest wall is expanding and expanding, right? So this lungs are expanding and recoiling, right? So the same, the chest wall is expanding. But if there is a pleural effusion in the one side or the both side, if one side will be there, so the one side will be the chest movement will be decreasing, right? With this, there is a decreased breath sound. As if we do the auscultation of this patient, on the auscultation we are getting the decreasing breath sound on the side where are the pleural effusion is there, right? With this, there will be the dullness is seen on the percussion. I hope you know about your percussion. As you're doing the percussion of the lungs, on the percussion we are getting the hyper resonant sound in the normal lung. But here, what we are getting, because there is exudates or the water is accumulating there, transudate or exudates will be accumulating there. Because of this exudate, what will sound in the percussion? We are getting the dullness sound of the percussion will be there, right? And there will be the decrease tactile perimeters. And if you are seeing there will be the decrease in the tactile perimeters, and there will be the deviation of mediastinum away from the effusion. As we are seeing, the like mediastinum are like, if we're talking about the trachea, so trachea will be the deviated away from the effusion, like on the left side. If there is the pleural effusion is going on, so this trachea will be diverted to the right side, so there will be the deviation of the mediastinal organs, right? And there will be the pleural friction drop will be seen there. So these are in the physical examination we are getting. The important examination, we are seeing the diminishing of the chest movement. The second, on the auscultation, we are getting this sound, uh, decreasing the breath sound, and when we are seeing the dullness on the percussion. So these are the important examinations. So you can see here, we are seeing, we are doing this palpation. So by the palpation you can see there will be the breath sound will be decreased, right? And on the percussion, when we are doing the percussion like that, right, when we are doing the percussion, so there will be the dullness is on the percussion chest, right? So dullness will be seen on it, right? If we talk about now what you have to do, the suction splash. What is happening in the suction splash? Please remember, when the body contains both fluid and the air, the body movement cause a splash, right? What the mean? If when the body is containing the both fluid and the air, right? This body will be movement. The body movement causes splash, right? Like feature of hydropneumothorax, as I already told you, right? And not in the pleural effusion. This is the feature of hydropneumothorax. What is happening? There will be the on the upper side, on the lobe of the upper side of this lung, we are having the air, and below in the lower lobe we are having filled with the fluid, right? So this hydropneumothorax, if air will be there and water will be there, so there will be the hydropneumothorax, right? And this is the scene in the horizontal fluid level in the hydropneumothorax, and that will be the horizontal fluid level will be seen on the our hydropneumothorax. Pleural effusion present with the concave fluid level, right? This will be the concave fluid level. And with this, access in thorax may be also result of the fluid filled stomach hitting into the thorax through the diaphragmatic hernia, right? Due to the diaphragmatic hernia, right? There is a fluid filled stomach is hurting into the thorax. Like it's looking like there is a fluid will be there, fluid and air will be there. So you can see by here, I'm showing you, you can see this is the concave like structure, right? And you can see this is the concave structure is causing, right? This is by the pleural effusion. And you can see here, this is the pleural effusion. This is the pleural effusion. But if I'm talking about the hydropneumothorax, you can see here, this is the blackish color of the air which is seen, and this is the horizontally line will be there, and this is the pleural fluid. So this is the hydropneumothorax. So this is the hydropneumothorax, and this is the pleural effusion. So this is the pleural effusion, right? And this is the structure of hydropneumothorax, right? So I hope you understand by this there is a concavity will be seen on the pleural effusion rather than on the hydropneumothorax. Due to the suction splash, we are seeing the horizontal line between the air and the fluid will be seen. The next thing, now we are talking about the important, which is about the tuberculosis effusion. If we talk about the tuberculosis effusion, what are the features of this tuberculosis infusion? The first thing, this will be the exudative. As we are talking about the exudative causes of the pleural effusion, we talked about the tuberculosis especially, right? And what will be seen, there will be the seen, the proteins will be seen increased, as we already talked. In the exudate there will be the more, but there will be the more and more proteins will be increased, and with this the pleural LDH is also increased, right? So if you are collecting a fluid, after this fluid you are going to the lab analysis. Through this lab analysis, if you are getting more increase of the protein and more LDH will be there, you are going to suggest of tuberculosis will be there, and it can be the hemorrhagic also. So as you are seeing in this patient, when we are taking out the sample of this fluid, this is mixed with the blood also, right? It's looking like a reddish exudate, right? So this is the filled with mixed with the blood also. So this is the hemorrhagic type. And if we talk about the glucose level are equal to the serum level. Like the normal serum level, as you already know, 90 to 120 will be there. So the near the 90 to 120 glucose level will be seen in the tuberculosis infusion. And the WBC count increase, the lymphocytosis, the lymphocytes will be seen in this X date. And the high level TB markers, if we talk about the high level TB markers in the pleural fluid, we have to do for the ADA. If ADA is more than 45 international unit per liter, it is giving the confirmatory of the tuberculosis. And the interferon V, if interferon V or interferon 5, if more than 140 picogram per ml, right? Interferon 5 will be more than 140 picogram, right? Interferon 5, right? It is also suggestive. And if the positive PCR for the tubercular DNA, right? Polymerase chain reaction is positive for the tubercular DNA. So this is giving the suggestive of the tubercular effusion, right? So please remember about the tuberculosis infusion. If we talk about some condition in with the low blood glucose, with the low blood glucose less than 60 ml per deciliter in the pleural effusion. These are our malignant pleural effusion, rheumatoid effusion, parapneumatic infusion, hemothorax, paraorganitis, Trigg-Strauss syndrome, and the glucose level in TB are usually equal to the serum levels, but if TB may present it with glucose, less than 60 mg per deciliter also, right? TB also can be present in the less glucose will be also seen will be there. So don't confuse what it is, that there will be the equal to the serum levels of the glucose in the TB. No, it can be less than also will be presented there. And which conditions where we are seeing the high amylase level in the pleural fluid? What is the causes? In the esophageal rupture, there will be the high amylase will be seen, and the pancreatic pleural effusion, right, will be there. As you already know, amylase are seen in our GIT, right? So esophageal rupture will be causing, and the pancreatic pleural. With this, also some malignancies there, like adenocarcinoma of lung or the pancreas, adenocarcinoma of the pancreas. These both type of malignancies also causing the high amylase level in the pleural fluid is seen there. Now further we are talking about the hemorrhagic pleural effusion. And the hemorrhagic pleural effusion will remember with the mnemonic bleed to death. Please remember the mnemonic bleed to death. And in which cases we are seeing the hemorrhagic pleural effusion. Please remember the first is the bronchogenic carcinoma and bleeding disorders. In these conditions, we are seeing the hemorrhagic. What the mean by the hemorrhagic pleural effusion? The blood will be going to accumulate in your pleural effusion. With this pleural effusion or the exudate, there will be the blood will be mixed with that, right? It will be the red color, like blood color will be there, right? Blood will be there, of course, right? Some lymphomas will be there, and the lymphomas also seen the pleural effusion will be hemorrhagic. And in the embolism, the pulmonary embolism is also causing our hemorrhagic pleural effusion. And extroversion, like aneurysm rupture, if some any aneurysm will be there, and due to this aneurysm rupture will be the hemorrhagic pleural effusion. Some diseases like SLE, systemic lupus erythematosus, this is also causing the pleural hemorrhagic type of pleural effusion. TB and trauma. Please remember about the TB. TB is also causing the hemorrhagic type of pleural effusion, and some trauma, maybe due to the road traffic accident, or maybe any kind of accident will be there, will be the involvement of the chest trauma will be there, thorax cavity will be there involvement. So due to this, the trauma, there will be seen the hemorrhagic pleural effusion will be seen, and some drug overdosing will be seen. Which drug? The warfarin and any kind of anticoagulant overdose. If any kind of anticoagulant overdose, there will be the bleeding tendency will be more, and due to this, there will be seen in the hemorrhagic pleural effusion will be seen, right? Now, if we talk about the pleural effusion with cholesterol crystal, yes, in the pleural effusion, we can see the cholesterol crystals, and this is seen in your hypothyroidism, tuberculosis, and the rheumatoid arthritis. These are the three which we're seeing with the cholesterol crystals. If we talk about the diagnosis, how we are going to diagnose the pleural effusion, please listen this part. We are starting the diagnosis first with the chest X-ray. With the chest X-ray, as you see on the screen, there is a two type of chest X-rays are given. We are going to take the AP view of anterior-posterior view of our chest X-rays. In the anterior-posterior view, you are gonna see that the on the lungs are totally will be the air. As you already know, air will be looking like black on the this thing. So as our lungs are filled with the air, it will be looking like trans transudative, right? But if you are seeing this, and we have to see on this X-ray, we have to see this CP angle. What is this CP angle? This is the costophanic angle, CP angle, right? Costophanic angle. If this costophanic angle is blunted, so you can see on this side, the costophanic angle is blunted, and you can see the fluid is accumulated here, right? And the fluid is accumulated here. This is the pleural effusion. So the first thing which you have to do, you have to do the chest X-ray. And in this also you can see here costophanic angle is clear, but here the costophanic angle is blunted, right? So this is the fluid which is here, and with the fluid, as I'm seeing in the pleural cavity, in the pleural effusion, there is the convexity will be seen, but here I'm seeing there is a horizontal line is seen in here. There is the fluid will be there, and this air, this totally blackish. You can see the normal lung, you can see there's a little whitish also and the black color also, because air just giving the blackish color and the lung is giving, the lung muscles are all giving the musculature is giving the whitish color. But you can see this is the total blackish color, dark blackish color. It means this is the hydro, this is the hydro pneumothorax. So this is the hydro pneumothorax, right? This is the hydro pneumothorax. So the first thing you have to do the chest x-ray in the diagnostic. After the doing this chest x-ray, you can do the pleural tap or the pleural centesis. What do they mean by the pleural centesis? The fluid is filled in the lungs. So what we can do, patient will be sitting in the upright position on the table, and what we are going to do the pleural is filled with this fluid, right? And what we are going with the syringe and the bag. We will push this thing. We are going to enter into the pleural cavity. As you already know, this fluid will pushing your lung to the pressing the lung to the opposite side. So as you are seeing here, the lung is totally pushed to the above, and this is the totally fluid is filled here. So what we are doing, we are entering this by through the needle, and this is attached with the cut cut here. I'm starting again. So what is happening, you can see here, this is the syringe which is attached here to the fluid, and it is accumulating all the fluid and drain out. This fluid will be collecting into the bag, right? So as you're seeing, this fluid is coming into the bag, it will be going to drain out, right? So we can do this thoracocentesis, right? Or the pleural tap in this condition, right? So please remember about the diagnostic algorithm of the pleural effusion. In the diagnostic criteria of this pleural effusion, so what we have to do, we have to do the first pleural effusion. After this, we have to perform the diagnostic thoracocentesis. We have to just take a small amount of the pleural effusion, and we have to measure the protein and the LDH, as I already told you, and it will be going to suggestive us the transudative or the exudative. Okay, as we already talked about the criteria, right? The protein will be if more than 0.5, it will be going to suggestive of the exudative, less than it will be the transudative, right? So with this all, if there is a more protein, more LDH will be there, there will be the exudative. If there is a less than the criteria, it will be the transudative. So if the exudative will be there or the transudative, so first talk about the transudative. As we talked about, the transudative cause was the congenital heart failure, cirrhosis, and the nephrosis will be there. So we have to treat the cause. If we treat the cause, there will be the resolvement of the pleural effusion. But if it's the exudative, so we have to do the further diagnostic procedure. In the further diagnostic procedure, we have to see the pleural effusion, glucose, amylase, and the cytology also we can see. We can go with the differential cell counts, what cells are in this pleural effusion for the carcinomas, right? We have to go for it, and we can do the culture and stain also. And with this pleural effusion, we can go with the markers of the TB also, right? TB markers. After this, if amylase is elevated, please remember, as amylase elevated, we know about the esophageal rupture or the pancreatic pleural effusion or the malignancies there. So we have to rule out and we have to treat this. But if there is a glucose is less than 60, then we have to talk about the consider as the malignancy is there or the bacterial infections or the rheumatoid pleuritis is there, right? But if there is a no diagnosis, then what we have to do, we have to do now the for the constrictive pulmonary embolus, we have to think about it, and we have to do the spiral CT of the lung. If it is present, the embolus is present, we have to treat the pleural effusion, and if no, then we have to go for the pleural effusion markers for the TB. And if it is positive for this TB markers, then we have to treat the TB, and if no, then we have to do the symptomatic improving. We have to observe the patient, or we can do the thoracoscopy or the open pleural biopsy. We have to take the biopsy of this thing, right? So this is the all the criteria through we have to do the diagnosis of it. And with this diagnosis also you understand about the treatment also, right? By this you understand if the exudative will be there, we have to go for the further diagnosis. If this is the transudative, then the transudative cause is the congestive heart failure, cirrhosis, nephrosis, so we have to rule out it. With this we can go for the TB diagnosis also, right? As the amylase was ablated is founded in the pleural effusion, we understand about it. This is about the esophageal rupture, pancreatic or pancreatic pleural effusion will be there, right? So we have to go for the further investigation of it and we have to treat about it, right? But if there is a pleural effusion is present and all things are the normal, right? And it is an exudative type of, so then we have to think about the pulmonary embolus. And we have, if the pulmonary embolus, we have to do the CT scan of the lung, right? In the CT scan, if we are finding the embolus, we have to treat the emboli. If not, then we are considering as the, we have to do the pleural effusion markers for the TB markers. We have to go for it. We can cultivate, we can do the culture staining of this pleural effusion or the LDH, ADA, all the values we are getting for the tuberculosis, right? If not, then we have to improve with the symptom and we have to observe this patient and we have to take the sample of the thorax. By this thoracoscopy we have to get the pleural biopsy, right? After getting this pleural biopsy we have to evaluate for the further for the malignancy. And this is all about our pleural effusion. I hope you understand very well about the treatment. We already talked to you what is the treatment of the pleural effusion, because pleural effusion is caused by the any disease. So what we have to do, we have to treat the disease, we have to treat the cause of the pleural effusion. The pleural effusion will be treated as well as, right? We have to diagnostic. For the diagnostic I already told you, for the diagnostic we have to start with the chest x-ray, then we can do the therapeutic thoracocentesis, you know. And for the further also, more and more fluid is accumulating there, there will be the more symptom will be there, dyspnea curve will be there. So what we can do, we can do the, as a management also we can do the thoracocentesis or the pleural tap. Uh, with this help of syringe and the back, we can remove the fluid from the lung, right? So this is all about the pleural effusion. I hope you understand it very well. Thank you so much.